I'm going to give an overview of the field of autoimmune neurology and related testing. I'm going to focus on central nervous system diseases, but the principles I'll discuss today are broadly applicable to all of autoimmune neurology. So here are some disclosures related to grant funding for the research that supports development of new antibody tests, and also some patents that have emerged from that. And we were also involved in some clinical trials for autoimmune encephalitis with industry. So the learning objectives are to recognize the key phenotypic or clinical features of autoimmune CNS disorders, and how one might have a higher index of suspicion for one of these diseases, to expand the differential diagnosis to include some new disorders, particularly non-paraneoplastic disorders, and incorporating those into our paraneoplastic testing, but starting at the bedside with the patient rather than the cause. So starting with how the patient presents neurologically rather than the cause of paraneoplastic. And then in that frame of mind, thinking about a phenotype-based approach and how that might guide testing. So taking the disorder that the patient presents with, whether that's encephalitis or a movement disorder, and then selecting the appropriate evaluation. So the kind of key clinical features are listed here. So really this subacute onset, so an onset that occurs over days to weeks with rapid progression rather than something very insidious and progressive over time. That's really kind of a key characteristic differentiator for autoimmune neurology from other disorders. There are many phenotypes or many clinical presentations that we will go through today. What unifies these diagnoses are well-studied and clinically validated IgG biomarkers. Supporting features that may give one suspicion would be inflammatory appearing changes on MRI imaging, inflammatory changes in the spinal fluid, such as elevated oligoclonal bands, capillary light chains, or white cell count. And in some patients, the electrophysiology, either an EEG or an EMG. And then for some patients, particularly for disorders where there's a lot of coexisting autoimmunity like GAD65, autoimmunity, a preceding history of autoimmune disease may be important as well. And where does this fit into neurology generally? Well, I think for the most part, it fits in with the other diseases of subacute onset. This includes not just the paraneoplastic and non-paraneoplastic autoimmune diseases we'll discuss today, but other disorders like multiple sclerosis, other inflammatory diseases like sarcoidosis, infectious diseases, brain tumors, spinal cord tumors, and then metabolic disorders where people can have a fairly rapid onset and rapid progression like vitamin B12 deficiency, or toxic disorders, or in some circumstances, patients with underlying psychiatric disease presenting with neurologic symptoms. So as far as kind of the phenotypes and how this then would maybe direct us towards specific tests, we can think of things in neuroaxis levels. And so starting from the top, you can have disorders affecting the visual system, so optic neuritis or retinopathies, encephalitides, epilepsies, and dementias, the basal ganglia, so movement disorders, choreas in particular, but also cerebellar disorders, ataxia, so another form of movement disorder, and then related disorders that overlap with between ataxia and brainstem function, or the brainstem encephalitides, which can present with mimics of Parkinsonism or ataxia, opsoclonus myoclonus syndrome, or other eye movement disorders, and then myelopathies and myelitis. And then the myelitis sometimes can be aligned with optic neuritis and neuromyelitis optica spectrum disorders, or MOGAD, MOG antibody-associated disease. And then it comes down to also the polyradiculoneuropathies and other forms of neuropathies, including the classical sensory neuronopathy or sensory ganglionopathy of paraneoplastic disorders, but also encountered in a non-cancer context. Nodopathies, mimics of ALS, and then various peripheral neuropathies. And finally, the last two groups to discuss, or last three groups to mention here, but we won't get into too much detail today, is neuromuscular junction disorders, so the original autoimmune neurologic disease, myasthenia gravis and Lambert-Eaton syndrome, more recently recognized autoimmune myopathies and necrotizing myopathies, and then autoimmune autonomic ganglionopathies. So as you can see, there's a lot potentially to cover. So we advocate for a phenotype-based approach. So thinking about the principal presentation of the patient and then selecting testing from there. And these antibodies, we need to be very clear about something. They're not all paraneoplastic. So a paraneoplastic evaluation really only covers causation. It doesn't really tell you anything about the neurological presentation of the patient, and only covers patients where they've an antibody with a suspected cancer association. So this quite limited evaluation has been in our laboratory for many years, and really came out at the time when paraneoplastic autoantibodies were being discovered, but is a very limited evaluation at this stage of the science of these disorders and the medical science and recommendations related to these disorders. So here's an example of one here, PCA1 or Purkinje cytoplasmic autoantibody type 1. So this is in many of our evaluations, our updated evaluations. So for example, autoimmune movement disorders, but this would be one of 15, 20 different biomarkers at this point, depending on the evaluation being ordered. Just to emphasize, the paraneoplastic evaluation does not include non-paraneoplastic disorders, and not including the more recent paraneoplastic markers either. So it's not even a comprehensive evaluation of paraneoplastic disorders. So we have removed this testing from our catalog within Mayo Clinic, so we cannot order this anymore. And instead, for a patient who presents with encephalitis, we recommend ordering an autoimmune encephalopathy evaluation that will cover both paraneoplastic and non-paraneoplastic causes. And that's just by way of example. The same applies for movement disorders, myelopathies, neuropathies, and so on. And so this is the approach. So on the left side, you see the evaluation. In the middle section, you see the suite of autoantibodies that is offered, from which an evaluation is composed. And then you see in the light green section, then the different assays that are brought to bear. And so for each analyte, there is an optimized way of testing for that antibody. So it's not just one system of testing. And so through all of the studies that we've been doing on a research and development basis, we know which antibody is most pertinent and for a particular evaluation, but also then which assay is the way to test for that. And then we get a readout then based on the antibody results, and then that's kind of the report that you get with not just the antibody result and the international units or whatever it is, whatever measure we're using, but then also an interpretation, because there may be more than one antibody positive, and then that will generate kind of a specific report in that patient. So to go through some of the disorders and try to emphasize some of the clinical points to be made, there's a disorder known as limbic encephalitis, which is a pretty classical autoimmune form of encephalitis. And these patients can present with memory, mood, personality changes, seizures. But to emphasize, it's not one antibody, one disease. So in the past, people would have mainly thought of maybe anti-Hu around one antibody, but then it was increasingly recognized there being more biomarkers over time. Some have strong paraneoplastic association, like ANA1 or PRIM5, and then others have virtually none, such as LGI1 antibody. But they can all present in the same way. But then it's been recognized over time that there are limited forms of presentations of autoimmune encephalitis or limbic encephalitis. So for example, autoimmune seizure disorders. So this particular patient here, he has an evaluation for seizures ongoing, and he develops a very specific form of seizure. You can see here this dystonic posturing of his face, his arm, and then his leg. So these are facial-brachial dystonic seizures that are very characteristic of LGI1 encephalitis. So these patients, unfortunately, do not respond to anti-seizure medication, but do respond to immunotherapy. So it's absolutely critical that this diagnosis is made. So in the past, people would have said, well, this is not encephalitis because the patient doesn't have altered mental status or psychiatric problems and just has this focal form of seizure. Sometimes these patients were diagnosed as having a psychiatric illness as the cause of the problems, but ultimately these patients are diagnosed by an LGI1 autoantibody test. But because patients can have diverse presentations associated with LGI1, or you can have patients with seizures as a clinical presentation that can have diverse antibody types, we don't recommend just one antibody evaluations. We recommend ordering an autoimmune epilepsy evaluation for a patient like this. So this particular patient, as is typical for LGI1 encephalitis, had a complete response and resolution with steroids. Then there are patients who kind of have more of a multifocal presentation. They can have multi-level, so limbic involvement, brainstem involvement, maybe peripheral and autonomic neuropathies, myelopathies, and ataxias. And this is now conceptualized in criteria for paraneoplastic disorders as an encephalomyeloneuropathy. And this has a very high index of suspicion for a small cell lung cancer associated antibody. So for a patient like this, you really could select any of the evaluations, encephalopathy, movement disorders, or myelopathy. The critical thing is not to order multiple serum tests or multiple CSF tests to cover all these levels. Each test, each evaluation will cover all of these possibilities. What's more crucial to remember is to order both serum and CSF to improve the diagnostic sensitivity overall. Another example of a disorder is what we would characterize as maybe non-limbic encephalitis, where patients can have diverse presentations, but ultimately are recognizable as autoimmune encephalitis. So again, it's very difficult to encapsulate this as kind of one antibody, one disease. And so again, we recommend profile-based evaluations. So here's one anti-NMDA receptor encephalitis where patients can present with a viral prodrome followed by various neuropsychiatric symptoms in different combinations, and then ultimately developed a progressive course leading to hospitalization, encephalopathy, and sometimes, unfortunately, coma. Again, to emphasize the importance of CSF testing, so it's really crucial to order both serum and CSF, because there are some antibodies that are more sensitively and specifically detected in CSF and others that are more robustly detected in the serum. So NMDA receptor and GFAP antibodies in the CSF, LGI1 and GAD65 antibodies in the serum. Here is the GFAP autoantibody. This is how we diagnose it in the laboratory by indirect immunofluorescence. So the same assay I showed you earlier that we diagnosed PCA1 and NMDA receptor antibodies, but again, a different appearance. So it requires that sort of expertise to really kind of pick out these different staining patterns and then reflex to a confirmatory test by cell-based assay. The utility of this testing goes beyond just making kind of the diagnosis. It also can save patients a biopsy, because this disease ultimately looks very similar clinically and radiologically to diseases such as vasculitis, CNS lymphoma, CNS sarcoidosis, which require a biopsy often to make that diagnosis. And so here are kind of some of the radiology that we can see with these patients, but to emphasize, not having the radiology doesn't rule out the diagnosis either. So some of these patients have normal imaging and may just have an elevated white cell count in the spinal fluid, and so it's crucial to kind of to consider a broad encephalitis evaluation to make this diagnosis. Another one that is now available as a standalone test and will ultimately be incorporated into our encephalitis and pediatric evaluations is GABA-A receptor antibody. And so again, this has some features that may provide diagnostic clues, but aren't entirely sensitive or specific either. And so consider broad antibody testing in serum and spinal fluid. So the findings can look somewhat like ADEM, where you have multifocal large brain lesions, but we don't tend to see post-gadolinium enhancement in these patients, unlike MOGAD or other ADM-like disorders. and we don't see brainstem or spinal cord involvement in this either. But so there can be some changes on the MRI that could be clues to GABA A receptor encephalitis. So then segueing down the nervous system to the basal ganglia and cerebellum, and thinking about autoimmune movement disorders. Here's the most common form, and so this is a patient who had a Calc11 autoantibody, and so you can see he has quite a profound gait ataxia. And so this is a patient who's very severely affected, obviously, and this very severe phenotype is also seen with some of the paraneoplastic autoantibodies like PCA1 or ANA1. But there are others like mGlu1 or Caspr2 antibody, where very often we don't find a cancer and the patients have they have the same clinical presentation, but ultimately don't have cancer and have quite a good response to immunotherapy. So these autoantibodies can provide that differentiation to know, okay, the patient has ataxia, it's probably autoimmune, subacute onset, but ultimately, what is the likely tumor association, likely treatment response and outcome? And so this is how we handle a lot of that in the lab. We look for the different tissue immunofluorescent staining patterns using mouse brain tissue slices. Then when we see specific staining patterns, we could reflex to a confirmatory test that's protein specific. So an overlap with autoimmune cerebellar ataxia is brainstem encephalitis, where you typically have ataxic findings, but then have other issues in addition, like an eye movement disorder, like you see in this patient, or can have problems with speech, swallowing, jaw movement, sleep, and ultimately could go on to develop problems with choking and with respiratory failure. So this particular patient had ANA2 and Calc11 antibodies in combination, and had a small metastases found of a testicular tumor. Ultimately, this patient was treated with IV steroids and cyclophosphamide and had some improvement. So this Calc11 antibody is worth mentioning, also because it can have more than one clinical presentation. And so this just emphasizes the point that although you may think of a very specific classical phenotype, such as brainstem encephalitis or ataxia with Calc11, particularly with hearing loss, there are some patients who present with limbic encephalitis. So you will see different antibodies in different evaluations. And so there is naturally overlap between the different evaluations. But again, to emphasize, you just need to order one serum, one CSF evaluation based on, I would typically recommend to go based off kind of what is the predominant presentation in the patient. So kind of moving on then to talk about maybe another autoantibody where you can have different clinical presentations. Here's one IGLON5 antibody, and this particular patient had more of a brainstem encephalitis presentation with this facial myarrhythmia, but also had some jaw dystonia, limited jaw opening, as you can see here, as well as kind of the myarrhythmia of the tongue. And so she had IGLON5 antibody. But here's another patient who had the same autoantibody ultimately, but presented with a different clinical phenotype. And so this was a patient who had chorea. And so you can see the kind of the hyperkinetic movements of the arms, the shoulders, the head and neck. But again, the clue here is the big clinical clue to differentiate her from Huntington's disease was that she didn't have a slower insidious onset. It was very rapid, and also no family history of chorea. So if those two things are true, think of autoimmune chorea. But again, this is not going to be one antibody, one disease. Ordering the autoimmune movement disorders evaluation will cover all of those possibilities, or at least nearly all of those possibilities. So here's just a list of other autoantibodies to consider for autoimmune chorea. So phospholipid antibodies, connective tissue disease markers, including lupus markers, are very important to order in autoimmune chorea. So a little more on that particular disorder. Here's a patient who had some behavioral change that occurred subacutely along with chorea, and that's very often the case with autoimmune chorea. Sometimes there can be clues on the radiology, like this PD10A disorder, where we have basal ganglial T2 signal abnormalities that occur. And many of these patients are immunotherapy responsive, particularly those with non-paraneoplastic disorders. So again, we need to, with chorea, we need to think beyond just the paraneoplastic disorders. We need to be thinking about the non-paraneoplastic disorders. And again, the phenotype-based approach can help with that. And here's another brainstem disorder, opsoclonus myoclonus syndrome. And typically people would think of, oh, ANA2, paraneoplastic, and that is important to think of, but there are many other autoantibodies that can present with the opsoclonus myoclonus syndrome. And this particular patient, in fact, had an autoimmune opsoclonus myoclonus syndrome, but was antibody negative. And antibody negativity is very important in this disorder because it'll tell you two things. One is that it's unlikely the patient has cancer, and secondly, it's likely the patient will respond to immunotherapy. So that's what we've seen in our Mayo Clinic experience. So then a brainstem/spinal cord disorder affecting the inhibitory pathways within those regions is the stiff person syndrome spectrum. And so here's a patient with glycine receptor autoimmunity and hyperexplexia as part of a stiff person disorder. So this exaggerated start response that's non-habituating. But the commonest autoantibody we see at this disorder is GAD65 antibody at high titer, greater than 20 nanomoles per liter, or greater than 10,000 units, or international units, if being tested by ELISA. So that's a kind of an overview of why we should be thinking about phenotype-specific evaluations, whether it's encephalitis, epilepsy, dementia, movement disorders, myelopathies, demyelinating disease phenotypes that look like NMO or restricted form of an NMO spectrum disorder, like recurrent optic neuritis or single episode optic neuritis in some cases where it's very severe, or longitudinally extensive transverse myelitis. There's phenotype-specific evaluations to think of those, and then also stiff person spectrum. And then I could go on also to talk to you about peripheral neuropathies, axonal and demyelinating, autonomic neuropathies, so an autoimmune dysautonomia evaluation, and then also myositis and necrotizing myopathy evaluations. So think, first of all, neurological phenotype, subacute onset, high index of suspicion. Do I order a serum test alone, such as for maybe an autoimmune dysautonomia, or am I going to order both serum and spinal fluid together for a CNS evaluation or for a CNS disorder? But all of these biomarkers don't just come from nowhere. We have to do a lot of research to kind of figure these things out. And so there are always new biomarkers coming down the track for us here in the Neurology Lab at Mayo Clinic. And so we have funded research that goes into this from a number of our consultants and directors looking for new biomarkers. And so we've an approach where we're screening these unclassified antibodies. That's collectively the 6 most common antibody in our lab. So individually rare, but collectively common. And then through these techniques of screening by protein arrays or phage display, we come up with novel biomarkers that we then go on to confirm as being specific using these techniques here, such as the confocal indirect immunofluorescence assay that you see here, or a confocal protein-specific cell-based assay at the bottom, or a protein-specific Western blot. And then sometimes we will find that the antigen itself is also expressed in the tumors of the patient, giving this more of a paraneoplastic significance. So this is an antibody reported in 2024, CAM-KV antibody. So these things take time to come into clinical service, and so this is one that we plan to put through formal validation so that we can implement it into our evaluations. But of course, if you get a seronegative result and you have a high index of suspicion for a specific disorder, or just in general that you think it might be an autoimmune disorder, you can always reach out to us through Mayo Clinic laboratories, and we can get back to you to let you know, did we see an unclassified antibody or some novel antibody that's not yet reportable in our profiles. So for this particular disorder, what we noted was very specific, kind of unusual radiologic findings of having patients with both T2 signal abnormalities in the limbic regions consistent with limbic encephalitis, and abnormalities in the basal ganglia. And indeed, these patients present with a mixed limbic hyperkinetic movement disorder type phenotype and are unified by having a cancer. And what was unusual here was that all the women that we found with this disorder had uterine cancer. So again, back to just to emphasize the complexity of this field, but we can make it easy from an ordering standpoint to think about how's this patient presenting, what's the phenotype. Am I going to order serum, CSF, or both, depending on the presentation? And then this will lead to a profile of autoantibodies. They're tested by optimized technology for each of those analytes, and then reporting out those test results, but then also giving a nuanced interpretive report based on the single or multiple autoantibody findings that occur. And then this will lead for you to be able to, for where cancer is relevant in that paraneoplastic context, to think of what cancer should I be looking for in that particular patient based on the antibody profile. But for some disorders, for LGI1 and Caspr2, for example, you might just be looking for thymoma, and less than 10% of those patients might be affected. In contrast, a patient with AMPA receptor antibody, the positive predictive value might be up around 70% for that particular antibody. And then you based on high index of suspicion, even prior to getting antibody test results, and indeed after confirmed antibody positive test result, this may lead to specific immunotherapies being considered, typically in the acute setting, corticosteroids, plus IVIG or plasma exchange. But then for some disorders, there may be specific immunotherapy recommendations like stiff person syndrome. IVIG has been studied very extensively in that disease, or rituximab and cyclophosphamide in combination, or one following the other in NMDA receptor encephalitis. So as you can see, there's a growing repertoire of these antibody biomarkers. As a result, this 9-analyte old-fashioned evaluation is now obsolete, and we urge people to use a phenotype-based approach to testing, which includes antibodies with both paraneoplastic and non-paraneoplastic significance, because this will ultimately give you the correct and accurate neurologic, oncologic, or non-oncologic information, and then also therapeutic and outcome data.